I have a question for Professor Kanioka. And and also Professor Moriato, are there patients where that are not candidates for intrinsic muscle activation with the TRA? And you say, listen, this you're just it, whatever the case may be, that they just are not candidates for physical therapy guided treatments to the intrinsics. And if so, what do you do with those patients?
Of course, we will try the motor control of TRA, and if it failed, we'll do some other treatment. But almost all patients relieved their pain. Of course, my patients is a little bit, I think the symptom is lighter than compared to Dr. Kurosawa's hospital. But for at least for athletes or at least for young patients, it might be effective. But sorry, but I had a old lady and I tried to teach her, but it doesn't do well. Yeah, she couldn't contract TRA alone. Yeah,
I was looking
yeah.
I was looking at many of your slides and trying to look at my patient population with your patient population and how I could incorporate some of those fantastic results and with therapy. And I think that the reason my question came about is some of my patients I don't think have really any obliques to speak of, and they're so deconditioned. A lot of them are status post long segment spine fusions,
Yeah.
and their core stability is just unable to activate like that.
Right.
However, my younger population, I think this is absolutely phenomenal and is a really nice avenue. Are there other intrinsic muscles that match the influence of the TRA with that we could also work on?
It's a pelvic floor muscle. Maybe the only two muscles are the intrinsic muscles. But lower multifidus might be a kind of a function. But
Okay,
pelvic floor is the next target to activate.
got it. Got it. Are there any other questions that any of our members have? Anybody that's on the line too, you're welcome to go off mute and ask me the questions of the faculty.
Could I ask Professor Kanioka where he put the PRP injection, please?
Sorry?
Yep, I can. Where, Dr. Kanioka, where exactly did you place the injections? Because on your images, it didn't look like you were doing them image guided. And so some landmarks, how deep, where did you place it?
It's exactly the same using a posterior SI ligament injection. So I did it blindly, and I think it must be in posterior SI ligament.
Okay.
Thank you.
Yeah, you're welcome.
Yeah, I think Pierre, you had talked about some of the hypermobility, I guess, of the front and the back of the pelvis together. Do you think there's I was trying to look at my patients that have concomitant osteitis pubis and pain in the back. And what do you treat first? How do you treat both of them? Are you injecting the front and the back to try and hit them both, or what do you do with those patients that have those athletes that you're seeing that are front and back?
Yes, no, I've actually treated some, and I've actually done both. I've done both the symphysis pubis as well as the SI joint. It's usually just been one SI joint. And I'm not sure why that was, just a couple of cases. But yeah, I would approach both of them because I think you've got to stabilize whatever's loose.
I think that Dr. Kanioka had a great picture of the whole pelvis shifting, where you had the pubic symphysis shifting, but you also had the SI joints shifting in the back. So both of your talks complemented each other, with that type of pathology where it's not just an isolated back issue, but there's instability in the front. And I think, I think that's a problem. I think it's an unsolved problem about what do you do in the patients that fail, but they have motion in the front? Do you fuse the whole ring or just the back? I think it's a question that needs to be answered in some patients. Well, fantastic. Any other questions that could come up?
I
Or
just wanted
comment.
to answer Daisuke's question that I saw in the chat. Sorry about that.
Mhm.
You know, the costs, you're right. We don't know what's the cost effective value of all these are. And hopefully the costs will come down. I inject where they're tender, where they're hurt. I do the ligaments. I go inside the joint. Whatever could potentially be the pain generator. And that's one of the points of that study that looked like really good data for that lumbosacral pelvic pain area was they were they're generous. And I am too. And I treat a shoulder, I'll do the rotator cuff, I'll do in the joint, I'll do wherever they're tender, and sometimes even more. So in terms of what it turns into, these cells, you know, they're modulating the system. And, you know, if you put them in bone, they become bone. You put them in, you know, the tendinous area, they're going to convince the local environment to be a tendon. You know, that's how they're kind of designed. So I don't see it creating bone in the tendon. We don't see that, and it doesn't really follow the science.
Thank you very much.
Just one other comment. I do think you have to go all the way around and hit everything that's going on, but you can't forget about the nerves, because the nerves are caught in the fascia. They may have been stuck there for years because of inactivity. I see that in a lot of exertional leg pain. And so you have to free that up. So lots of times you're hydrodissecting around the nerves, particularly in the more chronic cases, just to free that up.
And that's a good point, because when I do the spine, I do epidurals, and wherever they have radicular pain, I'll do into the actual neural structure. I've gone around perineal nerves and the knee, just anywhere that, you know, it's a biologic product that without I think the high risk that you see with some others. So, and I'm not saying I'm advocating for everybody to do everything. Everybody has to be a little cautious and make sure they are comfortable with this. I'm kind of definitely more on the, I hate to say it, the fringe, but you know, that's based on a lot of experience. And I've been doing spinal injections with steroids for over 30 years. So this to me is a safer deal.
Well, I think in the absence of more questions, then well, let me open up the floor one more time. Anybody from the audience or have any questions, or any of the faculty have comments they'd like to close with? Okay. Well, I know that I have learned a lot tonight, and I'm actually looking forward to Monday, where I can contact my lab and find out if I can get a BMAC study going on. And I also, you know, I work with physical therapists extremely closely for many of my patients, and the data presented here tonight on the intrinsics, especially, and the extrinsics, is some stuff that I just haven't concentrated on. So I think this is really going to elevate my practice, and I hope that people that watch this online and recorded, and the ones on the video tonight can take this home and help their patients. So with that, I think I'll close, and appreciate everybody's participation tonight. And in Japan, enjoy your Sunday. In the US, enjoy your Saturday night. And Martin, it's time for you to go to bed. It's about 2 a.m.
So
All right, good night, everybody.
Uti, I have a comment about that.
Yes.
I would like to share the next webinar of us. This.
Oh, great.
Just a moment. This is our next webinar. We have a plan, March in 2024, regarding SIJ biomechanics for understanding and treatment of the SIJ dysfunction or pain. So I'm looking forward to see everyone again there. Thank you very much.
Thank you,
the
Dr.
data will be finalized soon, and I will show the correct data on the website later. Thank you.
Fantastic. I appreciate that. Thank you for bringing that up. And I think also, you know, to capitalize on that, we're also expanding our webinar series, and we're also looking forward to having one with potentially pregnancy and SI joint disease with postpartum SI joint pathology. So that'll be another one for us all to look forward to. So Okay. Sorry, Daisuke. Anybody else?
Hmm.
Okay. Wonderful. Okay. Thank you, everybody. Have a wonderful night and